This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Clinical Neurology and Neurosurgery, published in 2026. The paper is titled, Prior Surgical Resection is a Predictor of Facial Nerve Function Decrement After Radiosurgery for Vestibular Schwannomas.
This is a topic that hits home for those of us in the OR and the Gamma Knife suite. We often think of Gamma Knife radiosurgery, or GKRS, as a primary treatment or as a secondary mop-up for residual or recurrent vestibular schwannomas. But the question has always been, does the nerve handle radiation differently if it's been touched by a bipolar or a dissector before?
Exactly. While GKRS is known for its excellent facial nerve preservation rates in primary cases, the authors of this study point out that it's poorly understood whether prior surgical resection influences the risk of facial nerve injury during subsequent GKRS.
Right. So walk us through the study design, Alara. How did they tackle this?
It was a retrospective study of 115 patients with vestibular schwannomas who underwent GKRS at their institution. They divided the cohort into two groups. Group A consisted of 19 patients who had undergone prior surgical resection before their GKRS. So these were cases of residual or recurrent tumors. Group B was the larger group, with 96 patients who underwent primary GKRS without any prior surgery.
And in terms of the radiosurgical parameters, were they comparable? Because if Group A was getting higher doses, that would obviously confound the results.
That's a great point. Interestingly, the median margin dose was the same for both groups, 12 gray. The tumor volumes were also relatively similar, so the primary variable here really was that history of prior surgical intervention.
And what did they find when they looked at the facial nerve function? I assume they used the House-Brackman scale.
They did. They defined facial nerve function decrement as any worsening of the House-Brackman, HB, grade following GKRS. The results were quite striking. In Group A, the patients who had prior surgery, 15.8% experienced a worsening of their facial nerve function. In contrast, in Group B, the primary GKRS group, only 1.0% experienced any decrement.
15.8% versus 1.0%. That's a significant delta. Was it statistically significant?
Very much so. The p-value was 0.015. When they performed the analysis, they found that prior surgical resection was the primary predictor of post-GKRS facial nerve function decrement.
This is a crucial finding for patient counseling. When we see a patient with a residual tumor after a subtotal resection, we often tell them that GKRS is very safe for the facial nerve. But according to this data, that risk is nearly 16 times higher if they've had a previous surgery compared to a radiation-naive nerve.
It really changes the conversation. The paper suggests that the facial nerve might be sensitized by the initial surgical manipulation. Even if the nerve is anatomically intact after surgery, the microvasculature might be compromised, or there might be subclinical trauma that makes it more susceptible to radiation-induced injury.
It's that double-hit hypothesis. You've stressed the nerve mechanically and vascularly in the OR, and then you hit it with 12 gray of ionizing radiation. Even a standard dose like 12 gray, which a healthy nerve handles without a problem, becomes a challenge for a nerve that's already been through a resection.
And it's worth noting that this study focuses specifically on the decrement after GKRS. So even if they started with a House-Brackman 2 or 3 after surgery, they were significantly more likely to drop further down the scale after the Gamma Knife.
Did the study look at the timing between surgery and GKRS?
The study focused more on the post-surgical status itself as the risk factor. The core takeaway was that the history of resection is the predictor we need to be watching.
For the residents and students listening, this really highlights the importance of the multidisciplinary approach. When we are planning a subtotal resection to preserve the nerve, we are essentially banking on the idea that GKRS will be the second step. We need to be aware, and the patient needs to be aware, that the second step isn't entirely risk-free.
Definitely. The authors conclude that while GKRS is an effective adjunctive treatment, prior surgical resection is a clear predictor of facial nerve function decrement.
It's a sobering but necessary piece of evidence for our clinical practice. We want to thank the authors for this contribution to the literature in clinical neurology and neurosurgery.
That's all for today's episode. We hope this helps you in your next clinic or tumor board.
I'm Dr. Aris.
And I'm Dr. Alara.
We'll see you next time on the Neurosurgery Hub podcast.